Let's go to the next one. Now, let's just really think about guidelines, all right? Okay, a Medicare patient with no symptoms or history of risk factors for colon cancer has a screening endoscopy of the entire colon from the rectum to the cecum, and no issues were found. How is this coded? A, G0105 colorectal cancer screening, colonoscopy on individual at high risk. B, G0121 colorectal cancer screening, colonoscopy on individual not meeting criteria for high risk. C, 45330 sigmoidoscopy flexible diagnostic, including collection of specimens by brushing or washing when performed. And D, 45378 colonoscopy flexible diagnostic, including collection of specimens by brushing or washing when performed, separate procedure. What say you? Come on, coders. Yes, you all are doing it. And I know we have a small crew, but you can do it. You can do it. That's right. Outstanding. All right, excellent. 100% of the people that answered said, come on, wow. Okay, let me pull that up a little bit. They said B, this is correct, because guidelines say, CMS mandates, hey, if you have a Medicare patient, you have to use a HCPCS Level 2 code in lieu of a CPT code when available. And this we do have. We have a more specific code on this board. So you all remembered the guideline. That's excellent. All right, here's another. The physician performs an EGD followed by manual dilation. The coding professional is unsure if the code for the manual dilation can be reported with the code for the EGD. What should the coding professional reference to determine the official policy on reporting these codes together? A, national coverage determinations. B, AHIMA website. C, current year's HCPCS annual update. Or D, National Correct Coding Initiative. What say you? That's right. Outstanding, outstanding. 100% of the people that answered said NCCI, National Correct Coding Initiative. And then I created this little chart. And if it helps you, then definitely use it. So I put the code sets up at the top. So if we're talking about CPT, you'll get the information that you need in this first column, ICD-10, PCS, and HCPCS. But this second row are the developers of the code set. Underneath it, these are the guidance publishers. These people publish the guidelines that surround it. So in this case, we're talking about a procedure called the EGD carried out by a physician. And when we're talking about procedures, this is definitely CPT codes for a physician. We're not talking about facilities, right? So AMA does publish those code sets. However, the guidance publishers, the principles of CPT is published by AMA, changes in CPT, AMA, but NCCI edits are by CMS. So that is the biggest difference. Also, let's take a look at ICD-10-CM. We know NCHC, they are the creators of ICD-10-CM. And the guidance publishers are AHA for the coding clinic. And then you have Medicare Coverage Database for ICD-10-CM codes, and also DRG if you're inpatient. And PCS codes are created by CMS, and then the guidance publisher, guideline publishers, AHA Coding Clinic, HCPCS, CMS, and the guidance publisher, well, remember this, Medicare patients must use HCPCS Level 2 codes in lieu of CPT if available. So there's no guidance publisher, okay? All right, so I got another question for you. All right, when coding excision of a skin lesion, when should a separate code for wound repair be assigned? A. Wound repair is always coded separately from excision of a skin lesion. B. Excision of a skin lesion and wound repair should be coded separately when the repair is intermediate. C. Excision of a skin lesion and wound repair should be coded separately when there is repair by ATT or adjacent tissue transfer. And excision of a skin lesion and wound repair should be coded separately when the tissue adhesion is used. What say you? All right, it's okay. If you need to say, wait a minute, these are regular AMA guidelines, right? Yeah. So this is what I would do. And you all, people are saying, hey, is it A? Is it C? Well, I'm eliminating A. And the reason why I'm eliminating A is because wound repair is always coded separate from excision of a skin lesion. That's not true. That's not true. What about excision of lesions? Bundle simple repair, right? If you go to excisions, right? And these are your guidelines, right? It says simple, I'm sorry. Yeah. Simple closures are bundled into the excision. Yeah, so you got to go. All right, now let's look at B. Well, let's skip B. Okay, let's look at C. Excision of a skin lesion and wound repair should be coded separately when there is repair by ATT. And coders, I do want to apologize. The ATT guidelines, they are, I don't know how they got left out of the MCG, but they are placed back in there. And you can write this in. Here are the ATT guidelines. Here are your keywords. ATT, XYZ plasty, rotation island flap, advancement flap, yin yang flap. And here are the guidelines. Excisions are bundled. Now, if solely undermining was carried out, you code it as a complex repair and code skin grafts separately. So C is incorrect because ATT bundles excisions. All right. And D, excision of a skin lesion and wound repair should be coded separately when the tissue adhesive is used. I didn't have room to put up the repair guideline, but tissue adhesives are not even coded. They're bundled. So we're going to get rid of you. And the answer is B. That was tough, huh? All right. So it's about your guidelines. These are AMA guidelines. All right, here's another, and I left the chart here for you to reference if you need it. Which of the following is not considered an authoritative source by CMS? A, American Hospital Association Coding Clinic for ICD-10-CM and ICD-10-PCS. B, the CPT Assistant. Or C, American Hospital Association Coding Clinic for HCPCS. Or D, ICD-10-CM and ICD-10-PCS Coding Handbook 2023 by AHA. Which one is not considered an authoritative source by CMS? This is a tough one. but we did review it. Okay, the answer. Okay, let's look at this. American Hospital Association for Coding Clinic is indeed an authoritative source, right? It is. They offer guidance for ICD-10-CM and PCS. The CPT assistant is also authoritative course because they offer guidelines for CPT codes. The American Hospital Association Coding Clinic for HCPCS is also an authoritative source. But D, ICD-10-CM and PCS Coding Handbook by AHA, this is instruction on how to code, but they're not guidelines. The other three are guideline driven. Yeah, somebody said, hey, this chart is not working for them. Oh, you better believe it. I'm going to fix that chart. Mm-mm. Okay, so the handbook is not even on there. See the CPT? Hmm. Hmm. Yeah, I got to fix that chart. I'm going to fix it. I promise. Okay. All right, so here we go. This is a summary of the entities that establish guidelines for medical coding. And you can always look at the playback as well. And these are the code sets and their guideline developers. Let me just double check one more thing. Oh, you know what? It's called CPT Assistant. So let me fix my little chart. Look at me going off my memory. It used to be called Principles of CPT. So CPT Assistant. All right, we'll work on this. Now, now, now that I've tried to give you a background on the 7 entities that develop guidelines for in medical coding, now it's time to turn our attention to AI. And I have a video. It's a short one.
Healthcare administrators are looking for ways to improve their revenue cycles and reduce costs. To eliminate time-consuming and tedious medical coding and address staffing challenges, Maverick Medical AI has found a way to harness cutting-edge technology to revolutionize your medical billing. Maverick Medical AI pushes the limits of autonomous coding by becoming the first company to surpass the 85% direct-to-bill rate. How? Maverick Medical AI's mCoder platform utilizes deep learning transformers and neural networks for medical coding with an astonishing 97% accuracy. This innovative technology securely transfers electronic health record data and performs autonomous analysis of the medical documents, delivering the output to billing systems within seconds. By employing an ensemble architecture that fuses deep learning AI networks with other machine learning algorithms and generates synthetic data examples to advance its comprehension of clinical domains. It can quickly adapt to new payer requirements and physician reporting styles. Trained on millions of records, delivering the required accuracy to significantly minimize the risk of errors, speeding up the claim reimbursement process, elevating your medical billing. Unlike other providers who promise gradual improvement, Maverick delivers immediate, unparalleled results through its proprietary deep learning AI platform. capable of accurately coding charts from unstructured clinical notes without any human intervention. No more frustration of high claims denial rates and missed reimbursement opportunities. Eliminate backlogs, delays, or coding errors. The fully automated M-Coder solution not only improves the process, but also elevates the role of coders, transforming them into auditors reducing operational costs and turnaround times.
Thank you. All right, so who got discouraged by listening to that? Yeah, in the chat. People said AI taking over. Oh my goodness. Ah, ah, ah. All right, so let's learn about AI. All right, so AI is the acronym for artificial intelligence. And in medical coding, it's the use of technology to bill and medical code. It's able to understand and interpret medical coding documentation through what they call natural language processing. In AI in medical coding will streamline medical billing and coding process and reduce errors and cost. So these are some of the benefits of AI in medical coding. And a lot of times you hear autonomous or autonomous medical billing. There are a lot of benefits. Of course, it increases efficiency. So it reduces the reliance on manual coding. And if it does that, you reduce the errors, right? And you save time, you save money. So overall, it's efficient. It enhances accuracy. So that AI software is going to produce the same result over time. They're not going to make an error. It's going to improve revenue capture. It's going to be in compliance with coding guidelines. There's not going to be any overthinking because they don't think. And also, they can do real-time coding. That means the turnaround time is going to be fast, and overall, it's going to save money. So this is a great thing for doctors. Yes, anytime you save money and you're efficient and all these wonderful benefits, it's great. So the current process, the current revenue cycle process is this. If you look at this wheel and you start at number one, when it comes to the medical, the entire medical experience, it starts with the patient the moment that they schedule their appointment. Then somebody from the office will have to verify the insurance. Number three, then when they come to the appointment, documentation is going to take place from the moment they come in to the clinical staff documenting to the doctors documenting. Then the medical coders will do their job and code out the encounter. Then they'll send it to charge entry. Then the billers will do claim submission. They'll submit it to the insurance company. Then the insurance company will pay and process the claim. They'll send it back to the provider for them to do payment posting. Then accounts receivable takes place within the office. Then they'll send out patient statements. And finally, there'll be some reporting. So that's 10 steps, and it happens over and over for every single patient. And we call this the revenue cycle process. This is what it is today, or before AI. So AI comes in, and this is what the revenue process looks like now. You have a front desk. The patient comes to the front desk. The patient gives or updates information if it needs to be updated, gives it to this front desk attendant. She puts it in the practice's electronic health record that contains this AI software. Then she sits down, they call her name, and she goes to see the clinical team who will confirm her diagnoses, ask her what's going on. They'll take her blood pressure, her weight, etc. They'll take that documentation and put it in the EHR. Then, when the clinical team is finished, the doctor comes in, and the doctor either carries out an exam or administers tests. And when they're finished, they'll put their documentation in the EHR. And then that information is sent directly to the insurance company, right? So the EHR is going to do what they do, and they're going to send it to the insurance company. What do? They're going to code it and they're going to bill it. Send it directly to the insurance company, and the insurance company is going to turn that around within 2 days. What does that mean? They're going to issue a payment or a denial within 2 days. And they're going to send that information back to that practice's EHR. And then the practice will send the patient a bill if anything is due. And they'll also notify the billing office if there are bills, and also give the billing office a copy of all of the remittance. Okay, so what happened? I think Miss Eva's back there. I'm doing my editing. Thank you. All right. So what happened? There's some people missing, right? There's some people missing. Okay, so this is basically the revenue process. And this is currently what's happening right now. And when you have basic encounters, such as office visits or even mental health visits, or encounters that kind of have the same billing over and over and over, this works. But you must have what we call clean claims. What does that mean? That means the insurance information has to be correct, the correct ICD-10-CM codes and CPT codes, all of that must be correct. And they have to follow all medical coding guidelines, which the EHR and AI can do. And they have to use timely filing guidelines. If we have everything, all the ducks in a row, then we can do this autonomous billing with AI. No problem. However, what if you don't have these clean claims? What do you do? Well, if the claim is not clean, the AI software will kick it out. Who are they going to kick it out to? They're going to kick it out to medical coders. And if a doctor's office doesn't have a medical coder to do it, they'll kick it out to the clearinghouse who can scrub it and clean it and make it just right so that you can put it back into the software for remittance and processing. So the bottom line is medical coders are indeed essential because you need qualified individuals to manage the EHR software. And together, we and AI, and I'm saying medical coders, will produce a highly efficient way to process claims. And if you think, oh, how often will it kick it out? All the time. That's very, very often. Um, it is, it is very, I cannot see in the near future AI completely um, processing claims 100%. I just can't see it. They don't have the capacity to use common sense in coding. They're more black and white, but there are some areas that call for subjectivity. A lot of areas call for subjectivity in coding, and AI just doesn't have the capacity to do it. And medical coders will work hand in hand with AI as auditors of AI. Yeah, and you will have to code too, because there are a lot of things that AI is unable to code, but they can code those straightforward ones. Like if you work in just a primary care office and you just do office visits all day, AI can kind of mimic that a lot, but you're still going to need a coder in there too. All right. So here is the revenue cycle process today. Let's say AI is fully functioning. This is your revenue cycle process. All right, so patient scheduling eliminated. Anybody ever hear of my chart? There you go. You don't need a team to schedule. People are scheduling their own appointments. Insurance eligibility and verification. AI can do that as well. If the patient puts their information in, the insurance can be verified. Patient documentation, that can't be mimicked. That is what the doctor does. That's what the clinical team does. So that cannot be taken away. Medical coding, that has to stay too. Who's going to monitor AI? Charge entry, that goes away. Claim submission and billing, AI will carry that out. Payment and processing posting, AI will carry that out. Accounts receivable and follow up, you better believe AI can do that too. They can contact you robotically. Patient statements, AI will do those, generate those, and they will also generate reports. So I think autonomous coding and artificial intelligence means medical coders will work as coders auditing AI. And even though I'm thinking it, this is what all of the documentation and publications are saying. So they're going to need you. And they don't just need people to pass the exam. No, they need you to know those guidelines. You need to know how to apply multiple guidelines. If and then and if and then. AI can't do that. Are you with me? Okay, so it's important for you to be among the highest trained in medical coding.
Thanks for tuning in, and until next time, happy coding!